for coming. It is my pleasure to introduce Dr. Thomas Lamb. He is the Director of the Office of Data Management and Outcomes Assessment at the Massachusetts Department of Public Health. This office was established in 2014 and hoping to leverage changes in health policy like meaningful use and advances in computer science to further public health goals. This particular interest in developing an integrated approach to evaluating chronic disease, nutrition, physical activity, and wellness. Dr. Lamb completed his undergraduate studies at the University of Wyoming and his graduate work at Johns Hopkins. So welcome, thank you.
Hi, thanks. Can you hear me? Can you hear me okay? Okay. I was told this has a range of 1,500 miles, so if you're not nice to me, I'll keep talking, but I'll leave the room. So when I talked to Lisa about coming here to speak, we were going over what the title of the talk may be, and obviously you can see that it's Public Health Informatics Figuring Out the Mess. The title that I wanted to give it was Everything I Learned from Horse Racing, but that was nixed. So anyway, we may get a little horse racing in here from time to time, but the point that I want to make is that the data that gets collected and used in the governmental public health world tends to be both of erratic quality, of difficult to connect together, difficult to use. Sometimes there are barriers for getting access to it that are maddening, but that we have more data than anybody. So this really, and we have access to more data than anybody. And so finding ways to navigate those waters, and we're trying to make the distance from port to port actually a lot shorter than it ever was before. But I think the point is that I think there's enormous potential both within the work that's done at the department and then working with partners outside the department in order to utilize this information. We are stewards of the data. And if we don't find ways to utilize this for the benefit of the citizens of the Commonwealth, and because there's health reform in Massachusetts, the information that we may glean from the data we've collected could benefit all states. So I've tried to select a number of different topics that I've worked on. And each one in its own way has a different version of messiness or complexity. And so I don't, again, feel free to interrupt at any time, but part of what I'm trying to do is not so much talk about the outcomes, but how we got to that point, and how the people who, in many cases, had limited knowledge. The first one is about medical claims. Well, I had never looked at a medical claim before I worked on this project, so I had to educate myself about medical claims. That's a pretty difficult world to work in. So, and in one way or another, all of these represent some level of an important project that public health is trying to figure out how it reinvents itself in order to address these issues, but at the same time provides useful information. So I've got information about the Mass Health Tobacco Cessation Benefit, Harvard Vanguard Brief Tobacco Interventions. I came from working on the tobacco world, which is why the first two are there. A program called Mass in Motion, and the Prevention and Wellness Trust. Does everyone know what all four of these things are? I'll quickly give you a quick summary if you don't. Wow, you're amazing. Everybody knows what all these programs are? Okay, so the interesting thing about the Mass Health Tobacco Cessation Benefit is that many states had versions of a tobacco cessation benefit to help people quit smoking using medications, counseling. Massachusetts had none. So we went from having no benefit to having a very complex and rich benefit overnight. In a sense, it was as close to a clinical trial as you could probably get in the public health world, because there was no data and then there was a lot of data. So that is how we approach trying to determine the impact of that program. I was talking a little bit earlier about the Harvard Vanguard data. Harvard Vanguard data is electronic health record data. It's it's an enormously rich potential data source, but it's also a very complicated data source to use. And one of the things that I'll talk about is people use the word systems change. So systems change is to imply that something in one state is different in the next state, and how do you actually look at raw data and define that systems change occurred? So that's part of what we had to do in Harvard Vanguard. Mass in Motion was former Commissioner John Auerbach's pet program. It was a public-private partnership to focus primarily on obesity and nutrition issues in Massachusetts. It was a policy systems and environmental change program, and it was in large part funded by the community transformation grants through the CDC. Prevention and Wellness Trust is as I was saying at lunchtime, I think it's probably the most important governmental public health program in the country right now. I've been asked to talk to more than a dozen states about the Prevention and Wellness Trust and how we will go about evaluating it. It is a fully funded program through the state of Massachusetts. We have $57 million to implement this program and evaluate it, and the goal of it is pretty straightforward: to reduce healthcare costs. It's the triple aim, essentially: improve patient experience, reduce healthcare costs, and reduce preventable health events. And finally, just what's next? So, and that's really kind of falls off of the Prevention and Wellness Trust, because I don't think you can evaluate the Prevention and Wellness Trust without making some changes in how we operate. So, the Mass Health tobacco cessation benefit. It's a policy change. So we went from having no policy of tobacco cessation for Medicaid recipients in Massachusetts to having a fairly rich one. And so this was included in Health Reform 1 in 2006 in Massachusetts, and it was legislatively mandated to have this insurance benefit included in the Medicaid insurance benefit program for all Medicaid recipients in Massachusetts. Prior to July 1st, 2006, there was no benefit. After that, there was. So they offered, for this pilot program, it was initially a two-year cessation pilot. They estimated that $7 million would be needed to fund the benefit, and that we were required to report to the legislature about the utilization and the impact of it. This, again, within the government, the fact that the legislation asked us to report to the legislature gave us enormous power in terms of being able to require different agencies to provide us with data, because all we had to do was point to the text of the law to say we have no choice. We're required by law to report on this. So the benefit design, as I said, we went from no benefit to having a rich benefit. There are 7, I think there's still just 7 FDA-approved medications for tobacco cessation. You probably see Chantix commercials on TV. But there's nicotine replacement, there's Zyban, there's a bunch of different medications that are used for it. The real difference between how Massachusetts implemented this and how other states implemented it is we had no prior authorization. So you did not have to. You could get a prescription. You could buy NRT at your CVS without having a doctor's prescription. It would go back to your doctor's. It would go back to the doctor, but you had enormous flexibility in how this was implemented. So some doctors, some states, particularly for refills, would require you to go back to the doctor to get a reauthorization of a prescription. It dramatically reduces the utilization of this. So where are we? So we didn't really know what to expect. I think when we were, the back of the envelope estimates of what we thought was going to happen, we expected 5 to 10% of this estimated smoking population in Massachusetts in the Medicaid population in Massachusetts to use this. We had a nice promotional campaign where we reached out to providers. We've got a program called QuitWorks, which allows people to do telephone counseling. There was also consumer promotion. all the beneficiaries of the Mass Health Program received information through the mail about the new benefit. It was embedded within their annual list of benefits in their package, so it wasn't as if this was something that was, we were on the 6 o'clock news every night talking about cessation benefits. So our expectations were what we saw other states have, which was a 5 to 10% utilization. So what we actually found was that 40% within the first 2.5 years of this benefit being implemented utilized the medications, primarily the medications. There's very little uptake on the counseling. Roughly 1 to 2% of people utilized the counseling. That's primarily, I believe, because there were very few counselors who were authorized to deliver the service. But what we had was essentially a pharmacy benefit that was highly utilized, that was far above the expectations for the state. So within about a month, if you can see this part here, we knew immediately we were going to exceed our 5% because the uptake was so dramatic in the first few weeks. So being good little evaluators, we said, how are we going to evaluate this? Now we've got all this information, and it looks like we may have something, at the very least, an interesting comparison to other states to say how many more people use this compared to Maine or North Dakota who had similar benefits but didn't implement it in the same way. So what we did is we formed a relationship with the Medicaid agency in Massachusetts, Mass Health, and we got permission to get all of the medical claims. This Department of Public Health also collects information through the BRFSS, which many of you are probably familiar with, to look at health risks of the population. So we knew we had two primary sources of information. We had utilization information from Medicaid, we had medical claims from Medicaid, and we had information from our own survey, the BRFSS. So this is what the previous 10-year trend for smoking in the Medicaid population from the BRFSS looked like compared to the uninsured population in Massachusetts. So there really was elevated smoking rates. The Medicaid smoking rate is roughly twice the smoking rate for the rest of the population. The uninsured population was high, but not quite as high, but it was a pretty consistent. This is obviously a smooth relationship. But this is what happened to the uninsured population for Medicaid, and this is what happened for the Mass Health population. It dropped 10% in 2.5 years. In the BRFSS, we found that 3 times as many people were making evidence-based quit attempts as reported prior to the Medicaid benefit being available to them. And this is the messiness of the data. So that was interesting, but it wasn't convincing enough. So what we thought is, okay, if people are quitting smoking, what is the most likely early warning system or early medical information that you would likely see? And it's not cancer, it's heart disease. So you're likely to see a reduction in heart attacks. I don't know if people have looked at any of the studies about smoke-free air laws around the country. It's now pretty much accepted fact that if you have a 15 or 20% drop in heart attack hospitalizations if you implement a comprehensive statewide smoke-free air law. So we thought, okay, well, let's look at the heart attack data. So what we found is a 46% decrease in hospitalizations for myocardial infarctions, a 49% decrease in hospitalizations for coronary heart disease, and there were some other, but we also looked at contrast. There were no differences in diabetes or in anything else that might make you believe that the data was flawed. It was only in heart disease. It wasn't cancer. It wasn't any type of cancer. It was just heart diseases, which is exactly where it should be. And we controlled for all those things on this in this analysis. Now, what was interesting to me was that I had to learn about the messiness of Mass Health data. So it's not just that they record the claim, but Mass Health has what are called eligibility segments. So you had to figure out when someone was covered for insurance to make sure that they were a reasonable person to include in your sample. So we had 70,000 people who were in our sample initially who utilized the benefit. The analysis was based on 17,500, something along those lines. But it was because people would have gaps in their insurance. And what you often have to do is just set up a criteria, and I believe ours was 321 days out of 365 days to be included in the sample for each year over at least a 2-year period. So we had about 4 years of data. We had 70,000 people initially. A lot of them were out because they just didn't have enough time in our sample. But these were things that all the group who worked on this had to learn how to work within this system in order to determine this. So the final result of this is the cost savings estimate. Initially, the state allocated $7 million for a 2-year period. We actually saw that we spent slightly more than that because the medications were used at a much higher rate than we had anticipated. But the cost savings based on MEPS data was roughly $2 for every dollar spent. Systems change. This is one where working with EHR data, and we had a discussion at lunchtime about the usefulness of EHR data. I'm a big fan of it, but I also know it's got enormous limitations. And so what we were trying to do with this Harvard Vanguard data was look at the brief, there's something called the 5 A's in tobacco control, where it's, I don't even know if I remember them, but it's ask, advise, arrange, assist, and something else. But you're trying to basically walk someone through the process of increasing their likelihood of making a quit attempt. So Harvard Vanguard records each of those 5 A's in their EHR. And they're meticulous about how they record their 5 A's. But the problem is that what you want to do is you want to say that the system itself changed. So that what we wanted to say was it wasn't just talking to patients that was beneficial. It was that the method in which they interacted with patients had somehow transformed from one state into another. So we had to create a definition of systems change based on EHR data. This is the workflow for Harvard Vanguard to ask questions about tobacco cessation. It's a pretty typical workflow. They actually have trained their entire staff on how each person is represented in different boxes in this pathway. So the medical assistants have a role, the doctor has a role, the nurse practitioner has a role, and different people ask different questions and record it in the database. What I found in looking at the Harvard Vanguard data is that they had an incredibly high rate of recording the information consistently from visit to visit. But one thing we wanted to do was assess the quality of the information. So if someone was recorded as never having smoked, then they should never have a previous visit that said that they did smoke. So we wanted to say that's one logical assessment that we can do with these 5A assessment data to say, look, if somebody said on September 17, 2014, that they never smoked, they should not have been there a year ago saying, I'm a former smoker. So we looked at it, and they had roughly a 98.5% non-flawed relationship within the data. So when they said never smoke, it always said never smoke. So even though the patients were in there 4, 5, 10 times, they didn't contradict their own data. So we decided, okay, well, based on what we can assess from this, we have a belief that this data is reasonably high quality to go to the next step. And the two things that we wanted to know were, how likely is it that someone quits smoking if you talk to them? And will they get healthier? So this is really what systems change data looks like. So you've just got all sorts of assessment levels over time, and each one of these there's 17 Harvard Vanguard sites. Each one of them either had a tobacco champion or did not. And what you can see is the ones down here had no tobacco champion. And the ones who have, like this purple line's really good, they had a tobacco champion, and their rate of actually conducting the 5As went from a modest 45% to 95% within a very short amount of time. So to us, we needed to then say, all right, so when do you define the point at which systems change occurs? Because what we want to know is, once you've made that change, what are the effects on the likelihood of quitting, and what are the effects on the likelihood that you're healthier? So what we did is we said, all right, we see no definition anywhere in the literature for systems change, so we're going to define it to be the likelihood, the month at which you are above 50% interventions, and you maintain that rate for at least 12 months after that. So, and never drop below. So that was our definition of systems change, and we wanted to say, okay, taking that point in time, what is the effect on the patient population at Harvard Vanguard? So this is what it looks like overall for all of the sites together, and what we found essentially is that if I can actually read that, that identifications plateau after roughly a year when you aggregate across sites, and that the interventions, so the deeper interventions, so there's an identification, ask whether the patient smokes, and then you actually do something about it with other people in the healthcare team. Both of these plateau. So this seemed like a reasonable definition to say, okay, at that point, so roughly a year, it seems like almost all these sites that have a champion meet systems change, that we can assess the impact of this. So this is what we found, that for every time the patient was asked and received an intervention for tobacco, they increased their likelihood of quitting by, I think that says 2.6%. And that their likelihood of having an office visit for a smoking-related diagnosis based on those diagnosis codes that are the Surgeon General's report decreased by 4.3%. So every time you visit, you are decreasing your likelihood, you're increasing your likelihood of quitting, and then you're decreasing your likelihood of visiting for a smoking-related illness. So, but the only way we could do that was, one, to deal with a fairly messy world of EHR data, which none of us had ever worked with before. But we had to begin by creating definitions that were logical in order to determine whether this was reasonable data. We were talking about when do you get to the point where you have preponderance of evidence? Because I think any one of these studies has any number of flaws to say it's not a clinical trial, it's not a perfect world, the data's messy, my definition of the data, never smoking versus not never smoking, maybe there's 7 other ways to assess that would indicate that the data's worse than I thought it was. So what we've done is we've started looking around the country for other studies that actually can see similar patterns. And so we found one in New York City, and we found one in Louisiana, where the data sets show almost exactly the same pattern. They haven't done the health effects, but it's roughly a 2.5% decrease in the likelihood. Does anyone know what the Public Health Service guideline says is the impact of an intervention? Decreasing the likelihood, they say 30%. So our data says 2.6%. So it's measurable and it's important, and we can count people who quit smoking as a result of it, but this is not pie in the sky. It's not like all you have to do is ask doctors to talk to their patients, and then all of a sudden the tobacco problem will be solved a year later because everybody will quit smoking. It's clearly tiny little incremental changes that have to add up, but if they don't reach systems change, you don't get that little mountain of tiny things together.
What was the definition of a smoking-related office visit?
So it was anything that had one of the first 3 diagnosis codes with diagnosis codes that were in the appendix of the Surgeon General's 2004 report, I believe. So going even further into the messiness of the world is the Mass in Motion program. Mass in Motion, again, was championed by former Commissioner John Auerbach. and it is a policy systems and environmental change program. It started out as something that was a public-private partnership between the health insurance foundations and the Department of Public Health. When the community transformation grants were funded, it became primarily something related to that. We went from 13 communities to 52 communities. So these are the Mass in Motion communities, and they came on board at different points in time, which are the different colors of the map. You can see they're all over the state. And if you know what those communities are, sadly there's 351 towns in Massachusetts, so it's kind of hard to know which one is Waltham and which one is Somerville, et cetera. But the point is that they represent a fairly diverse but generally unhealthy collection of communities. So they were chosen in part because we wanted to work with communities where we thought we might be able to have a larger positive impact if the program was successful. So the problem from an evaluation perspective is that is a mess. So this is sort of the theory behind what the Mass in Motion program is supposed to do. So I'll just start this animation. So imagine that you live right here, and you live in a community that's got some, a little bit, there's a bike path, and there's a walking trail, some healthy restaurants by the Carrots, a park over there, community health center there. And this person lives over here. It's pretty much the same environment for that person. And so the point is that Mass in Motion was trying to enrich the environment for the patient. So this is more or less what happens over time. So there's more bike trails, there's more healthy restaurants or grocery stores selling healthier foods. But over on the other side, maybe over time, just because of population changes, you get a few more things on board. But Mass in Motion is looking, by the end of 2015, it's a much richer environment. So the theory is that if you live in this richer environment, you have more things close to where you live than this person does. So initially, if that circle was around you, there would be no difference. So the theory is that as time goes on, you should see a difference in both the attitudes and the activities that the person who lives in the enriched environment would engage in. So we decided we would collect a whole bunch of data. And so we had 15,000 telephone surveys that were staggered over time, primarily using BRFSS questions, but some other questions that were specific to community and Mass in Motion. We went out and did field assessments of communities. So it was parks, sidewalks, restaurants, grocery stores. We assessed menus of restaurants in town. We went through all the aisles in a grocery store and assessed the healthiness of the food in those stores. And then we also geocoded all that data. So we knew where the people lived. So when we used an address-based sample when we were doing our telephone samples, and we said, okay, that person lives here, and we know a lot of things about that neighborhood. So we situated every person in that environment. But we had nowhere near enough money to evaluate 52 communities. So what we did is we did a latent class analysis of communities in Massachusetts in order to create a typology of them that became our framework for evaluation. So we had 52 communities. We looked at, I believe, 57 different health, infrastructure, and demographic information by town, so census data, other administrative data, how many heart attacks were there, how many people had diabetes based on other estimates from other data sources. And we found that this typology, and we said, okay, well, we've never used this before, but we don't have the money to collect data in all 52 communities or go do the field assessments in 52 communities. So we're just going to pick representatives of these type classes and then comparison communities that were also in those classes. And we ended up with 28 communities. I believe it was 18 or 19 communities that were Mass in Motion, and then 8 or 10 comparison communities. We only had 9 of the 10 classes represented in Mass in Motion communities, but we had a comparison for every one of them. So we thought, okay, that's affordable. We can proceed and do this. And so what we did is we decided what we needed to do is create this sort of person-centric analysis of the impact of the mass in motion policy systems and environmental change. And so what we wanted to do was say, all right, so what exactly do we have? So what we thought was part of our definition of this has to be based on the size of the neighborhood that the person lives in, their psychological perception of where they live. And so we thought, all right, well, why does that have to be the same size for everybody? Why isn't it something that is unique to the individual? So we said, all right, so we wanted to look at whether someone lived in this neighborhood. And so we said, okay, so we put in our little magic push pin again in the map, and we said, so by some definitions, we'd say this person doesn't live in this neighborhood, but they would fit into this neighborhood. So we said, all right, there's probably characteristics associated with larger and smaller neighborhoods, and we wanted to know which ones would define the likelihood that someone was in an enriched environment or not, and that over time that would relate to changes in behavior. So what we found is that the larger neighborhoods were related to younger employed and people, and those people who were aware of mass in motion. They had heard of the program. And that the smaller neighborhoods were related to older unemployed and people who were not aware of mass in motion. And this was a fairly simplistic little geographic model, but we thought, all right, this is a starting point. We'll be collecting data over time to refine this model. But we said, all right, there seems to be some basis to say that the neighborhood is unique to the person or is definable by the characteristics of the person. And that what we now need to do is look at those potential changes in the person's behavior or their attitudes. And so what we thought is let's take a look at the question was in the past month, this is one of our telephone survey questions, in the past month, would you say that your family or family members bought more fruits or vegetables than the same month a year ago? So our telephone surveys were winter-summer telephone surveys. Our field surveys were in the summer. Our telephone surveys were March and September. So we thought, okay, we're a March comparison to March should have some commonality. A September comparison to September should have some commonality. And what we wanted to say was, so what defines a bigger or smaller effect? So what we thought is a lot of this stuff is it's not something that we can control. So we can't control age, race, ethnicity. This is sort of, we just got rid of all that stuff because that's really not something that our program addresses. And these were the things that we thought we could work with. And so we said, we have a program, Mass in Motion is a program of healthy markets. So healthy markets, we try to promote healthy markets. We put little decals in people's windows, say you're a Mass in Motion healthy market. We wanted to know, is there a relationship between, in the past month, would you say your family bought more fruits and vegetables to their proximity to a healthy market? So if the healthy market was 10 miles away, our expectation was that there would be very little impact of it. But if it was across the street, hopefully you said you were buying more healthy markets. And if we went to that same market year after year and saw that it's even healthier than it used to be, then we should see more changes over time. So what we found was healthy markets didn't really have that big an effect. It was significant, but it wasn't really a huge effect. But it was awareness of mass in motion. So just the knowledge that something was happening in your community almost meant that people sought out those healthy markets more than they did. But what we also found was that there was an interaction that was actually larger than healthy markets. So knowledge of mass in motion, along with the fact that there was a closely proximate healthy market in your neighborhood, increased the likelihood that you would answer yes to this question. So what happened next? And that's the public health world sometimes. So in January of this year, they cut all funding for the Community Transformation Grant. So the program, as it was constituted, was completely defunded. So the state has found some additional funds to complete the evaluation of the data from the Community Transformation Mass in Motion program, but there's no more money for this program as it was originally planned. So a different kind of messiness. The data itself was messy. It was a complicated question, but this is a reality, particularly where this money was actually related to the Affordable Care Act, and there were people in Congress who were not fans of the Affordable Care Act, and so it went from a fairly reasonably funded program, we got $3 million a year, to zero literally overnight. So
What was the messaging in the Mass in Motion? What were they aware of?
So we had two questions on the surveys, and one was just, have you heard of the Mass in Motion program? And the second question was, do you know what the Mass in Motion program is? And we had a couple of distractor questions. One was about transportation, one was about education. And then one option was, I don't know what it is. And so we actually had a lot of people say they knew what, they had heard of Mass in Motion, but they didn't know what it was. But we only took the people who said that it was a health and nutrition program in their community. I don't remember the exact wording of it, and that they said yes to the question. So you don't get the second question unless you said that you had heard of Mass in Motion, and we target ourselves to the people who had answered yes and got the second part of it right.
Could you say how you determine what a healthy market was?
So it was actually a really elaborate process. Took about an hour to go through a grocery store and assess all. There were dozens of different categories of it. Each market got a score. Pretty much any large supermarket would get a high score. So you may not have a lot of healthy, low sodium beans, for example, but they would have them. So but a healthy market might. So you might have two healthy markets. One might have a higher proportion of healthy products, but you're really talking about the convenience stores and the small neighborhood stores that tended to be less healthy. But we did other surveys and found that there was 5 to 10% of people who got their primary food source were these small markets. So even though people tended to shop in the larger markets, there were a lot of people who got the food on their table every night from these smaller markets, and so we thought that's not an insignificant group. They tended to be less healthy in the other questions we were asking, so we thought this was a reasonable way to attest it. That was just an example of one of the things we would have looked at, but I think that what we were trying to do was say that over time, if we can increase the healthiness, we should begin to see positive changes in behavior.
You mentioned getting those stores to stock more
Yeah.
fruits and vegetables.
Both that and just stock any in some cases, because some of them really had no healthy products, and so just getting them to begin to stock them. And we worked with them on how do you present food in an appealing way. So we showed them how to display the products, the healthy products, in ways that might be more likely to get purchases. So the Prevention and Wellness Trust Fund is something I've sort of ate and slept with for the last year and a half. It's an incredibly complicated program. I think the beginning a sense of what we were trying to do, we had developed this open source software for connecting clinical sites to community-based organizations that was bidirectional, so a community-based organization could actually deposit data into a medical record. And we thought that's a tool that ultimately can be utilized by the Prevention and Wellness Trust, both as a way of evaluating the effectiveness of the interventions, but also as a way of promoting the conversation between clinical and community partners, which we saw was terribly fractured, that nobody had any idea what other groups were doing. There was a lack of respect, and that what we really wanted to do was promote the conversation on a common language. And so the community people could never talk in clinical terms because they could never assess what they had done in clinical terms unless they had an exorbitant amount of money to do an assessment of their own work, and that just never happens. So most of these are very underfunded, small groups again. And so the Prevention and Wellness Trust Fund, again, written right into the law, which again has enormous benefit, is to reduce the rate of the most prevalent and preventable health conditions, to increase healthy behaviors, adoption of workplace wellness programs, reduce health disparities, and to form a stronger evidence base. And so part of what we're trying to do is reduce healthcare costs. This is part of health reform. Health Reform 2 was essentially a healthcare cost. Healthcare 1 was about health insurance. Healthcare 2 is about reducing healthcare costs in a way that we can demonstrate also does not impact the healthiness of the population. So we have $57 million over a 4-year period. Takes a long time to ramp up in a program as complex as this, so it really is $57 million in about 3.5 years. So the point is that what we have to do is we actually have to demonstrate reductions in preventable health conditions and reductions in healthcare costs or the growth of healthcare costs in 3.5 years. So you have a very narrow field of health conditions that might be amenable to quick reductions in healthcare costs. You are unlikely, if you are looking at the data, to say, I'm going to focus on cancer. I think cancer it's really what I want to do. It's very important to me. Get those people to quit smoking, and 20 years from now, we'll have a reduction in lung cancer. And that's true, but the legislature would not have patience for that. So we thought, all right, so what do we do if we've got a 3.5-year window? So what we looked at were 13 health conditions, and they're listed on the right, that we thought there was reasonably good evidence that over time, it wasn't perfect evidence, but reasonably good evidence that over time you would see reductions in healthcare costs. There's an advisory board for the Prevention and Wellness Trust that's made up of representatives from insurance companies and academia, health economists, other groups, local public health, who received a 2-page fact sheet from the Department of Public Health about each one of these conditions, and then they met to advise the commissioner on which of these health conditions should be included in the Prevention and Wellness Trust. And I can tell you what they voted for, which was, they voted for obesity. And there's no evidence that obesity that you can impact healthcare costs in 3.5 years with any obesity program that we know of right now. But there is pretty good data for pediatric asthma, for some things for hypertension, for oral health, actually has dental sealants, substance abuse, falls in older adults. These were things that there are existing programs that for pediatric asthma is incredibly expensive. Just getting a child to go less often to the ED tends to easily save enough money to implement a program. And the programs are really elaborate. It can be you give the family a vacuum cleaner, you give them new sheets, you go in and you do an assessment, you clean their house for them to get rid of the triggers for asthma. A very expensive program, but very cost effective at the same time. So what we did is we said, all right, so what we wanted to do was we wanted to have our goal for this entire project was to maximize the likelihood that we would succeed in delivering the outcome that the state legislature asked us to do. So again, in this sort of messy world of information where there really is no solid data on most of these things, what we had to do was come up with the closest evidence we could to say how large a population should we work with. So obviously if you just said I've got $57 million and I've got 6 million people in Massachusetts, I'm just going to give them all $10. So, and then say, go be healthy. So that's one way of doing it, or go buy some celery or something like that. So that's a way of spending $57 million pretty quickly, but that's not likely to have much impact on people because they don't like celery. But So what we had to do is we had to look at it and say, so based on the closest evidence we had, which in many cases was worksite wellness programs, which are not the greatest things, we wanted to say, what's the sweet spot? What's the peak of the distribution for increasing the likelihood that we will show a positive result? And it was really between 60 and 120,000 people in an area that would be enough money to measure an effect and not too much money, because anything under $30,000, if the program was under 30, we thought we wanted to have, say, 6 to 12 programs, because we didn't actually have the capacity to administer more programs than that. It's hard to administer these programs. So we said, all right, let's say we've got about 10 programs. We ended up having 9. But if we had 10 programs of 30,000 people, that's 300,000 people. We thought our data shows us that's not the most efficient use of the money, but it was closer to 600 to 700,000 people was ideal. Well, it's not, the world isn't always perfect. So here are the grantees for the Prevention Wellness Trust: Berkshire County on the left-hand side, Holyoke, Hudson, Worcester. Worcester's a really interesting one because they just took different zip codes that were the most unhealthy zip codes in Worcester. We also wanted to stack the deck so that we wanted really sick populations, so it would be easy to bump into somebody who needed service. So these are all the places that met those criteria. It was if you know anybody who applied for the Prevention and Wellness Trust funding, they probably are not ever wanting to go through that grant application again, because it was, I think the average length was 400 pages for the application. But it was because we required them to provide a lot of data about the partnership. Who are your partners? How are they going to work together? What population do they serve, so that we knew that we were actually going to get a lot of sick people in our sample, and that we would have as many chances as possible to deliver services that were likely to impact the population and reduce healthcare costs. So this is the 4 primary health conditions were hypertension, pediatric asthma, tobacco, and falls among older adults. And so what we found was we hit the target in a sense, because the colored lines are the average of the 9 grantees, and the gray lines are those that are the statewide average. So we were roughly 25 to 70% above the statewide average for the 9 grantees for these health conditions. So we have an unhealthy population, we have a size, a number of grantees, and the size of the population that we thought was close to the ideal size for being able to maximize our chances of showing an impact. These are the health conditions that the different sites did. We didn't require everybody to do all 4. They were all required to do at least 2. There were interventions. Everybody's required to do the bidirectional electronic referral. Every one of them has to do that. That's in part because we think that promotes the extension of healthcare into the community, that if they do that routinely over time, they're more likely to have that conversation last after after the money stops flowing to them. So if they develop a trust with each other, they'll continue that conversation. The only one that actually surprised me was Worcester. Worcester did not do tobacco, and they've got one of the highest smoking rates in the state. So they decided, and we talked to them after the fact, and they said, we think we already have enough tobacco programs. This is where we don't. So people had explanations. It was actually fascinating to read those 400-page applications. I read 10 of them. So, but it was the justification that people put together was really fascinating, because I think it really demonstrated how well they knew their communities. It's just that they weren't talking across clinical and community or municipality. No one really ever sat down as a group consistently. So the what's next part of this is the Prevention Wellness Trust is so incredibly complicated in terms of the numbers of interventions, the different types of interventions, the people, the different communities, how do you do comparison groups, that this requires an informatics solution. You can't actually, I don't think, do this, fulfill the request of the state legislature without an informatics solution. So our first step was just saying, what pieces of this data system can we connect together? And so what we wanted to say was the Department of Public Health has an enormous amount of hospital data. We now have access to the all-payer claims database, which is every medical claim in Massachusetts for anybody who is publicly or privately insured. We have all the clinical partners in the Prevention and Wellness Trust, not all of them, but some proportion of them were required to give us their clinical data so that we could do quality improvement work with them to ensure that they were screening the patients properly, that they were referring them when they had the opportunity to. We will be G-coding all the data, so we'll be putting people into the community in which they live with some fuzzy adjustments so that we can't know exactly where anybody lives. And this is the bidirectional e-referral system, so we know what services were delivered. If it was a 6-class diabetes prevention program, we'll know that the person went to 5 of those classes and missed the 3rd one. We'll know that they did tobacco cessation, but they only did the first 2 counseling sessions. We'll know that they did not show up for things if they were referred to them. So we know that people were screened positively and did not actually avail themselves of the services that were provided. So that's just a nice picture. And so that's not going to actually get us the answer. And so what we're doing right now is we're building a data warehouse. So the data warehouse is our vision of how these pieces come together. It's likely to be a federated data warehouse because CHIA, the people who own the all-payer claims database and the case mix data, the hospitalization data, are a quasi-governmental agency, and they're already building their own data warehouse. And so they're telling us it's really smart for us to not try to rebuild their section of our house, but to utilize what they have and just connect through essentially it's a web-based system, connect to the internet. So we have a lot of data at the Department of Public Health. We've got the MDPH net system, which I won't go into a lot of detail, but it's an ambulatory surveillance system where we get access to clinical data. A lot of the partners are doing that. And then the Mass League of Community Health Centers also offers us data on their clinical partners. So I think the point is that what people do, the users, and we hope that you will ultimately become users as well, is that they will submit queries to this linked data system across all of these data sets in order to answer these very complex questions that any one data set cannot answer. And that's it.
Question or 2? Dan?
I'm just curious, when will the data warehouse be accessible?
So, so money's always an issue, but for internal use, we actually trained 2 people to get access to, right now what we have is the all-payer claims database and 10 years of death files on it, and we're doing a test to do a probabilistic linkage between the death files and the APCD in sort of an initial test phase. So we have a couple of people who are working on it right now, but the goal is to have a public-facing portion of it next July. So I don't know what that means yet, but I think it's really to try to figure out ways to work with partners to break down some of the barriers between the Department of Public Health, but maybe on sort of a narrow view so that we have so that everybody gets more comfortable with each other in terms of just making freer access to data. Our commissioner has stated over and over and over again, timely data, relatively free access for internal and external partners.
Did I understand you correctly that you, for Mass in Motion, you asked individuals what their neighborhood was and then you
No.
built it? Okay.
No, what we did is we wanted to, I got to remember exactly how we did this, but what we did is we looked at it, it was we asked them for information about their neighborhood. Is there a healthy market in your neighborhood? So we asked them questions that would actually locate points in there. And so based on that, we looked at the distance between the address in the address-based sample and the positions that they, the locations that they cited, and we fixed a radius around them that way. I actually don't think a circle is the right model. It's probably some other shape, probably tilted toward businesses. It's probably oblong wherever the direction of the businesses is, but we didn't get that far.
Can you talk about any of the privacy issues you run up against? So the MDPH net it just mentioned that you have access to clinical data.
Yep.
And I'm wondering what that means.
So it took about a year to get all the legal agreements in place for MDPH Net. It is a query-based system, so analysts at the Department of Public Health, it's not like you submit you're working and running SAS code and then 5 seconds later you get an answer. It might be 3 days later you get an answer. It's a gatekeeper model where the clinical partners can all review, but they also can set the criteria for whether or not you are a preferred customer, so to speak, and that they can actually allow people to go through right away. So there are no preferred customers right now, but there are, 20 clinical partners on this system, Cambridge Health Alliance, 20-some community health centers, and Harvard Vanguard, and they each have their own gatekeepers.
But the clinical data refers to specifically identifiable people?
So we don't actually get access to the individual, the directly identifiable fields. So we don't know names, we don't know birth, we don't know social security, address, but we have all the clinical information. So lab tests are available in this system, diagnosis codes, which is what we often use. But you can also create definitions within it. So you might say, my definition of medication adherence is blah, 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 blah. And so it's number of prescriptions written through a period of time. So this is what I was saying with some of the stuff with Harvard Vanguard EHR data. There are very few definitions of these from EHRs that exist right now. I think the Office of National Coordinator is trying, and CDC are trying to create a pool of definitions for how you use electronic health records, but there's really not much out there right now. So you may end up having to create your own definition of something like medication adherence.
Okay, thank you very much.